So we'll start lecture 31. I have right at 30 minutes, so I don't know if we'll finish it. Some of this we've already talked about, so we might be able to. All right, lecture 31, we're going to talk about some miscellaneous procedures in blood bank. We're going to review adsorptions again, elutions, and some other special testing in blood bank. All right, so we want to talk about the process of antibody removal methods, and those include elutions, where you are eluting off the antibody that is coating the patient red cells, okay? Now, whether you're performing that elution to test the red cells, all right, so if you remove that antibody that's coating the red cells, then the DAT will be negative, so you can repeat that DAT, and then you can obtain a patient phenotype, or you can do a true weak D interpretation. Okay, so remember, if your patient has a positive DAT, meaning that something is coating patient cells, that could interfere with your weak D testing because it uses the same reagent. We're using AHG reagent, okay? And then we'll talk about adsorptions, and then the mini cold panel. We'll talk a little bit about it again as well. All right, so the purpose of the elution, we're really trying to determine what's coating patient cells. And this is of huge concern if your antibody is of IgG classification, meaning that that is clinically significant. All right, so what elutions does, whether it be a heat treatment, Louis freeze, or some type of acid treatment, it will dissociate the antigen-antibody complex and allow the antibody to dissociate from the red cell membrane. Okay, so that's the purpose of elutions. When do we use an elution? Anytime you have a positive DAT, we want to perform an eluate to remove that antibody. That once we perform that elution, remove that antibody, then we will run that eluate against our panel. All right, so we can identify what's coating the patient cells. And we will do an elution anytime there is hemolytic disease of the newborn suspected that we guys talked about before. And remember, Louis freeze is the optimal elution technique used if ABO, hemolytic disease of the newborn, is suspected. We will use an acid treatment if another IgG antibody is suspected. We will do elutions in a transfusion reaction workup when the DAT is positive to determine what is coating patient cells. And we will do elutions when a drug-induced reaction is expected to. Anything that involves a positive DAT results in an elution. And then what happens is the eluate is tested against the panel cells. And it can be the same panel that you performed your initial panel on if your IAT is positive. If your eluate is pan-reactive, meaning that it reacted with every cell and the autocontrol is positive, that typically indicates that it's a warm autoantibody. And so the types of elution: acid. We use the acid to dissociate warm and autoantibodies from the cells. All right, so that lowering of the pH will dissociate the antibody. It usually destroys the cells as well, so we're only testing the supernatant. That's where the unbound antibody is now. Okay, so this eluate is not good if you need to test the red cells. You can commercially purchase these kits. It's usually called Eluclear. So that's the acid treatment. You can also use organic solvents to denature the antigens by dissolving the red cell bilipid layer. Some of these are ether and digitonin. You can commercially purchase those. And then you can use heat or Louis freeze. Louis freeze is your freeze thaw. Those are used when you suspect any type of ABO, hemolytic disease of the newborn. All right, so the elution process, what's going to happen here is you're using patient cells. Okay, I want you guys to understand that's what you're testing, patient cells. You want to make sure that you wash these. So usually you'll do about 4 to 6 washes. We want to make sure we remove any unbound antibody, okay? So the only thing we're concerned with in elutions is what's coating the cells. So we perform these series of washes to make sure we remove any unbound antibody. That's very important. And when you perform that last wash, you will, when you perform this washing procedure, you will save that last wash. It must be run in conjunction with the eluate, all right? And so that last wash must be negative to indicate that all of the unbound antibody was adequately removed. Okay, so your last wash must be negative. So you're going to go through a series of washing. Now you have your adequately washed cells. Then you'll add your acid if you're using an acid, or if you're freezing, then you will put them in the freezer and then rapidly thaw. Once you do your acid treatment or freeze thaw treatment, then you are going to, that results in cell lysis, all right? So then you are going to spin down that tube. You're going to have a lot of cell lysis, so your cell button is going to be very small, and then you're going to be left with a supernatant. That supernatant is what we call the eluate. That is where your antibody is. Okay, so now you have your eluate and your last wash. You will run them in conjunction with each other. You can use your panel cells. For Louis freeze, you can do what our mini panel that we talked about during our hemolytic disease of the newborn cases, where you run A negative cells, B negative cells, O positive cells, O negative cells. You can do that for investigation of hemolytic disease of the newborn. For all other antibodies, you'll have to use your panel. And so the purpose of the elution, again, is we're identifying the antibody that was coating patient cells. Just like I mentioned, that antibody cannot be included in the final wash. So if you perform an eluate, you run your final wash, and your final wash has reactions, that indicates there's antibody in that last wash. That indicates that the wash was not appropriate enough. You have to repeat the whole process. All right. So here's your elution principle. This is what's going on. So you have your patient cells in plasma. Note in this that you do have antibody that is coating the patient cells. That's what's causing our positive DAT. We want to know what is coating patient cells. Okay, so we're going to do a series of washing. Notice after a series of washing, we have removed all of the unbound antibody. Okay, so we're only focused on what is coating the red cells. So we've done 4 to 6 series of washing. We have our patient cells that have been washed. We have our last wash, right? So your patient cells are going to be treated, whether it be an acid treatment or a freeze thaw treatment, okay? So then after that treatment, you spin down your sample. Notice that the antibody has been dissociated from the red cell membrane. So now the antibody is suspended in your supernatant. So right here. This is all we are concerned with. These cells have lyse. They're no longer viable, no good for testing. Okay, so the only thing that we're concerned about is this antibody. All right, so then you'll take your antibody, all right, that has been eluted off the cells, and your last wash that from your series of washing. Then you're going to run it against your panel cells. Okay, so you're adding in panel cells. This antibody, if the antigen is on the red cells, we will have agglutination. Remember, there's no antibodies in the last wash, so our last wash will be negative, okay? If that antibody matches up with the antigen present on our panel cells, we will have agglutination. We will be able to identify what antibody is coating patient cells. If you had a positive DAT due to complement, you will not have any agglutination. All right, our panel cells are unable to detect complement. All right, so it's possible you have a positive DAT but a negative eluate. That is possible. And so here's what you have. You have your sensitized red cells with the antibody coating the red cells. After you perform the elution procedure, then you're left with that unbound antibody. We have eluted that antibody off of those red cells, and then we can test it against our panel and look for patterns of reactivity to see which antibody is coating patient cells. In the event of a delayed hemolytic transfusion that is due to JKA, then what is coating patient cells would match the pattern of JKA. All right, so then we would be able to confirm that the patient did indeed have a delayed hemolytic transfusion reaction due to anti-JKA. All right. So just some different varying reactions. So in the event that you have a warm autoantibody, your DAT is going to be positive, your IAT is going to be positive, your panel is going to be pan-reactive. When you do your eluate, if a warm autoantibody is present, it's an IgG classification, your eluate is going to be pan-reactive as well. It will react with all of your panel cells. If you have antibodies to drugs, such as what we talked about in penicillin or hydroxychloroquine, you're going to have a positive DAT, but your eluate is going to be negative because our panel cells cannot detect the drug. All right, that's why our eluate will be negative. And then complement, remember, our panel cells cannot detect complement either. So while the patient has a positive DAT, our eluate will be negative. And then like the example I mentioned earlier with the delayed transfusion reaction, you'll have a positive DAT, and then the antibody will match the pattern of reactivity for the corresponding antibody. Whatever antibody the patient had is now coating the donor cells, okay? And this little note here, I think I mentioned this earlier, oftentimes in delayed hemolytic transfusion reactions, you will see the antibody attached to the red cells before you see it overflow into the patient plasma. All right, so it's oftentimes that your DAT will be positive. It might yield anti-JKA or JKB, but your patient's IAT will be negative. This is the reason why the DAT is so important in transfusion reaction workups. Right, it's positive that DAT is going to be positive first because of the antibody coating the cells before it appears in the plasma. All right. All right, so just a little bit of language differentiation, and I know I am guilty of this as well. In blood bank, we typically only do adsorptions. So ADSOPTIONS, that's adsorptions versus absorptions. So adsorption is the uptake of antibody by the target antigen. So if you think about when we're doing an auto adsorption, we are taking patient red cells, mixing it with patient plasma, so those red cells can adsorb out the antibody in the plasma and absorb it onto the red cells. So adsorption out of plasma, absorption onto the red cells. Okay, so does that make sense? So adsorption, you have a target antigen site that is absorbing on the plasma, the antibody from the plasma. And I'm guilty of this. I use those words interchangeably, but it should be in blood bank, it's adsorption. And so we talked a little bit about absorption in the previous lecture, but just to reiterate, and I might have failed to mention this earlier too, adsorption, you want to make sure that you use the optimal temperature. So if you are trying to absorb out a cold autoantibody, you want to make sure you do that at 4 degrees. If you're trying to absorb out a IgG warm reacting antibody, we want to make sure that we do that at 37 degrees. Okay, so it is temperature dependent. And like we mentioned, you guys do not forget this. This is a really good board question. You cannot do an autologous absorption if the patient has been transfused within the past 3 months. And again, the reason for that is because those donor cells are still in circulation. And remember, the purpose of an absorption is we're trying to absorb out that patient's auto so we can identify any underlying antibodies. But if that patient has been recently transfused, those donor cells might be antigen positive and could also absorb out that allo antibody. Okay, so then we could misidentify the presence of any allo antibodies. All right. And then again, remember that auto absorption or the differential adsorption process could have to be performed multiple times, and you still might not yield a completely negative plasma. All right, so you might not be able to get all of that auto antibody out of the patient's plasma. So the reagents used in the absorption treatment, we want to use chemicals. We want to break up that disulfide bond. All right, so what we want to do, we will treat the patient red cells with DTT, and again, we're just breaking up those bonds. And we are able to break up those bonds, dissociating the autoantibody from the red cells. And then what we can do is use those autoantibody-free red cells, mix it back with patient plasma where the autoantibody is. So then any existing autoantibody that's in the plasma is now absorbed out of the plasma and absorbed onto the red cells. Okay, so then you're left with autoantibody-free plasma, which you can then use to identify any underlying antibodies. But remember, DTT removes the KAL antigen sites from the cells as well. So if that patient does have an underlying KAL antibody after this treatment, we will not be able to identify that. And sometimes DTT can also be used for the removal of IgM antibodies as well. ZZAP could also be used, and again, ZZAP is a mixture of papain and DTT. Again, it's just a further treating of the cells to allow for antibody uptake onto the cells. But remember, if you add in that enzyme, you're also destroying the antigen sites of your MNS and Duffy systems as well. So you will not be able to identify the underlying antibodies if it's one of those categories. And we talked about this in the previous lecture, using patient cells for an auto absorption versus using known reagent cells for a differential absorption. All right, so performing a mini cold panel. So if you do suspect you have a cold reacting antibody, we could perform a mini cold panel, and that's just mixing patient plasma with a known set of cells, and those known set of cells usually include your screening cells 1 and 2. You'll perform an auto control as well. I have also seen blood banks include cord cells, and as well as really, so that's it, because your screening cells are your O cells, your auto control, and then your cord cells. To help differentiate big I from little I, because those are the most common cold reacting antibodies. All right, so here's a little mini cold panel, and we're given polyspecific reactions and monospecific IgG reactions. So notice our auto control is positive at initial spin, so this is a auto antibody, and because it's only reacting at initial spin, it is a cold reacting auto antibody. Notice that at 37 degrees, that antigen antibody is dissociated, so we have negative reactions. And if you only use monospecific IgG, you also have negative reactions. However, if you are using polyspecific AHG for your testing, then the complement that has been activated by this IgM cold reacting antibody will also be positive. Okay, so that's why you have reactions with polyspecific. I want you guys to understand how you can have positive reactions at initial spin and at AHG when a cold reacting antibody is suspected. So if you have reactions at AHG, that indicates that you are using polyspecific AHG. Okay, that's why most clinical blood banks will only use monospecific AHG in the IAT, okay? And so a lot of blood banks now, they've skipped the immediate spin or room temperature reactions of the IAT. For instance, if you're doing the gel technology, you don't have any initial spin or 37 reactions, you only have AHG. And that has really gotten rid of all of the cold reacting nuisance antibodies, such as big I, little I. And then also some thiol reagents might be used to disperse autoagglutination as well, to break the bond of those IgM antibodies. Right, so one way that you can disperse this agglutination from a cold reacting antibody is you can warm it up to 37 degrees. This would be like a pre-warming technique. So you warm your patient plasma, you warm your reagent cells, and then you mix them together, incubate them together, and then you will read for agglutination, okay? And then so some known antibodies that are known to cause this interference, MN and Lewis. There are some instances, if your patient has a severe cold autoimmune disease, then you might even see some reactions at 37 degrees as well. If you suspect that you have a cold reacting antibody that is acting at 37 degrees, that one is considered clinically significant. All right, so there are some instances we will see that with anti-M. It is known to be both classification of IgM and IgG. Anti-M is known to interfere with our back types as well as react at 37 and AHG phase of testing. When anti-M is reacting at AHG, it is considered clinically significant. So we want to make sure that we do AHG phase of cross-matching. Now, whether or not you give anti-M compatible or M negative units, that is debatable and depends. Some facilities will give AHG cross-match compatible units. They will say that is satisfactory. Some institutions will say, no, you have to antigen type those units for anti-M, okay? Or I guess antigen type for the M antigen, sorry, not the antibody. All right, so here's your mini cold panel like I mentioned. You'll have your O cells, so these would be screening cells 1 and 2, your cord cells, and your auto control. Some people, if you're trying to differentiate anti-IH from IH and I, they might include the A1 cells and the A2 cells. In my experience, our mini cold panel only consisted of the O cells, the cord cells, and the auto control. And so something you guys need to be aware of, differentiating anti-big I from anti-H and anti-IH is usually not clinically necessary. However, if your lab wants to take it a step further to identify what exactly antibody is reacting, then you would want to include the A1 cells and the A2 cells. But for all Board of Certification purposes and for this course, you need to understand that the reactions based on A1 cells and A2 cells determine the strength of these reactions based on the amount of H substance that is present, okay? And then we talked about that in the previous lecture as well. We've talked about PEG in the past, polyethylene glycol. It's an additive that increases antibody uptake. It removes the water from the test tube, so it allows more antibody uptake. The downside to PEG is that it can enhance warm autoantibodies, okay? So you even might have some false positive reactions with using PEG as well. So if you think you have a very weak IgG antibody, PEG is useful. But however, just using it on a normal basis, if you already have a strong reacting antibody, it enhances those reactions. So it's not really necessary to use PEG, only if you're trying to strengthen a very weak reactant. All right, so then we also talked about our antibody titer. We've talked about this before. This is a method used to determine the concentration of an antibody present in the plasma. This is very useful when we are doing mom and baby studies. How strong is mom's antibody could determine how the amount of stress the baby is on. So the higher the titer of mom's antibody, of an IgG antibody, means the more antibody is able to cross the placenta and coat more of baby's antigen sites on the red cells. And so when doing an antibody titer, you will perform some serial dilutions, and usually it goes all the way from 1:1 to 100 to 250, 1 to 256. And then you will take an aliquot of each of these dilutions. You're going to mix it with a known series of panel cells, and then you will read for agglutination. And then your titer is interpreted by the last tube that provides a 1+ reaction, okay? So if you have a 1+ reaction in your 1:16 tube, and then a negative reaction in your 1:32, your titer is reported out as 16. So when you are doing maternal studies and a pregnant female is identified to have an antibody, we always have to titer that antibody. All right, so we want to establish a baseline titer. Usually if mom has a circulating IgG antibody, she is considered high-risk pregnancy. She will probably have more frequent visits to her OBGYN, and each time that she visits, they are going to draw her blood. And we will continuously follow the formation of that antibody by performing a titer. So let's say 3 weeks ago, we had a pregnant female who had anti-D in her plasma, was titered at 1:16, okay? So now she presents again to her OBGYN. Now her titer is 1:64. That is a greater than 2-tube increase. So that is considered clinically significant. We can conclude that baby is probably Rh positive. Mom's anti-D is coating baby cells. Mom is being exposed to baby cells. Mom is actively building anti-D. Right? Her titer is consistently going up. That baby is probably in respiratory distress. Could indicate either a intrauterine transfusion or early term delivery. So we will run the previous titer and then titer from the new sample. We repeat the old one with the new one. We run them side by side in conjunction with each other. And then again, we can use that titer to determine if mom's positive IAT is due to true anti-D or passive anti-D, meaning that she was given RhoGAM recently, all right? So in a true anti-D, that titer is going to be significantly higher. It will continue to rise. In a RhoGAM scenario, that titer is usually very low, about 1 to 8, 1 to 16. However, when we repeat that titer 3 or 4 weeks later, it is going down, right? So that's one way we can differentiate anti-D due to RhoGAM versus true anti-D. And again, if that patient has true anti-D and that titer is continuously going up, that patient will probably result in early term delivery. So the downside to performing titer, very similar to some of all of our blood bank testing, is interpretation of agglutination. So subjectivity from tech to tech, identifying that tube that has the last 1+ reaction. So we've talked about the titer being reported out as the reciprocal of the tube that has the 1+ reaction. Some institutions might even do a scoring. So for each dilution, there is a score with it depending on the strength of the reaction. You guys don't have to memorize this by any means, but just so you're aware, some institutions might do this. And so if the reaction is 4+, that's a score of 12. If the reaction is 3+, that's a score of 10. And then a score of 2+ is 8, 1+ is 5, and then a weak plus is 2. And then so you would add all of those up, and then negative reaction is 0. Add all of those up, and then you're assigned a score. So the higher the score, the higher the titer. I personally have never used the scoring system, but some institutions might use that. So just so you're aware, you don't have to memorize that though. You do have to know that the titer is obtained from the tube that has the 1+ reaction. So the last tube where you see agglutination, okay, that's your titer. And then there's also high titer, low avidity antibodies. And so these guys react weakly at AHG. They're non-reproducible results. Really, they interfere with testing for other antibodies. And usually they're not clinically significant except for the Cartwright antibody. There's some other antibodies that are considered high titer, low avidity, and those are Chido-Rogers. And I will say, when I was in blood bank, we had a patient that we suspected that we had Chido-Rogers. And so, again, these antigens are not routinely included on your antigram. If you look on your panel and flip it over on the back, it will list what rare antigens are present. And so Chido-Rogers is one of those that is listed on the back. So what you're going to see with these HTLA antibodies, you'll have some non-specific reactions, meaning that it won't match the pattern of any of your antigenic profile. You're going to have some random positive reactions in there. And then what happens is they're high titer, but they cause weak reactions. So even though they're high titer, we do not get strong reactions in our blood bank testing. So you always have to keep these in mind when you have non-specific reactions. All right, so there's 3 methods that may be used to remove antibodies. They're through elutions, and those elutions include Louis freeze and ABO, hemolytic disease of the newborn. There's another elution that should have been included in this. So the elutions that we talked about, the Louis freeze, the acid, those all involve cell lysis. You can do another elution if you are trying to preserve the red cells in order to obtain a adequate phenotype or RH expression, all right? So you could do a chloroquine diphosphate treatment, all right? So that just dissociates the antibody from the red cells while saving the red cells. It doesn't lyse the red cells like your other ones do, other elutions do. And then another one is the glycine EDTA treatment. And we've talked about that before. So for instance, if you had a patient that had a positive DAT and you were doing weak D testing on that patient, and that positive DAT was causing your RH control to be positive, that invalidates your RH. So in order to resolve that weak D, you need to perform a glycine EDTA or a chloroquine biphosphate. That will dissociate the antibody from the red cells, and then you are able to repeat your DAT. So you've removed the antibody, what was coating the red cells, and now your DAT is negative. Now you can repeat your RH testing and perform a true RH determination. Is that patient really weak D positive, or was that weak D reaction due to the antibody that was coating the cells? And I do want to make one thing clear. I don't know if this has been mentioned up until this point. We've talked about phenotyping. When you phenotype a patient, you are determining the antigenic profile of those cells, all right? So you're determining if the antigen is positive or negative. If your patient has been transfused within the last 3 months, you cannot obtain an adequate phenotype on that patient, because there are donor cells in that patient's circulation that might have a different antigenic profile than your patient, and you could obtain a false phenotype of your patient. Okay, so if your patient has been phenotyped within the last 3 or transfused within the last 3 months, you cannot serologically phenotype that patient. Right, so options include taking it to the molecular level. So if you have a patient that's being consistently transfused and then the IAT pops up positive and you want to know if the patient is antigen negative or positive, you cannot phenotype that patient. You would definitely want to do some molecular testing to get a true antigenic profile. And then we also talked about absorptions, and then we talked about the mini cold panel, and then we talked about the use of titering in maternal studies. So that concludes lecture 31, and I'm just a little bit behind schedule, 5 minutes over. So does anybody have any questions? All right, so I will see you guys tomorrow at 10. We will do 33 and 34. In the meantime, if you have any questions, feel free to email me or call me. All right? You guys have a good day.
Thank you. You too.